Yeah, so we'll begin, sir. Good evening, everyone. So today we have with us Dr. Deepak Madhu. Dr. Deepak Madhu is a consultant gastroenterologist in Caritas Hospital in Kerala, and he has done his DM from AIMS. And I actually used to be a patient when sir was a senior resident in the ward. So yeah, I'm very pleased to have you, sir, and thank you for giving us your valuable time today and like telling us about such an important topic which I think a lot of patients think about, but like it gets talked about often a lot, but there's not much clarity on what to do about it.
Thanks, Nikhil, for the introduction, and thanks for giving me this opportunity to educate patients who are, having ulcerative colitis. Uh, I hope this awareness program for colorectal cancer would improve the life of people with ulcerative colitis. And it's been a long time since we met, Nikhil. The last time I saw you was probably in 2018 when you were
Yeah,
admitted maybe to ward.
yeah.
And nice to meet you after a long time. Okay, I'll share my screen. I'll go directly to the talk. So is my screen visible to everyone?
1 second, sir. 1 second. Yeah, it's visible now. Yeah.
Okay. So this is the talk for mainly intended for patients. It's not for practicing clinicians or epidemiologists. It's for patients. It's on what patients need to know about preventing colorectal carcinoma. Patients with ulcerative colitis, what they should know about preventing colorectal carcinoma. So I think we had just shared the. Can you tell me the results of the poll? Uh, I
Yes.
mean,
Yes, 1 second. I'll tell you. Uh, it's actually 60% of people voted no on both the questions,
mhm.
and 20% of people yes on both, and 20% yes for awareness that they require screening for colon cancer but know about that they will have to do it after 8 years of disease.
Okay. So anyway, there is a significant proportion of people who need awareness, and a good number of patients who actually need to get screened.
Yes.
This number should be people who have gotten screened should be somewhere above 80% or even 100%. Should definitely be 100%, and 100% of patients with ulcerative colitis need to know that you know uh, they have a higher than average risk of developing colorectal cancer. So I hope all of you are ready for the talk.
Yes.
Brace yourself. Many of you would be hearing shocking things, but this is not intended to shock anyone. It's intended to make you aware that I need to be ready for screening. I know having cared for a lot of ulcerative colitis and Crohn's disease patients, I'm aware that a lot of people are averse to getting a colonoscopy done. you know uh, but once I'm done, I think uh, you know people would take screening colonoscopies a little more seriously. So once first, this is the overview of my talk. This is how I'm going to go about the topic. First, I'll introduce you to the magnitude of the problem, tell you who's at risk, and how to mitigate the risk by medical and screening measures, and how to undergo follow-up. So the magnitude of the problem. So there was this meta-analysis which was published in Gut 2001. It's pooled data from a lot of studies. The probability that a person with ulcerative colitis, left-sided or pancolitis, would develop colorectal cancer at 10 years is 2%. At 20 years, after he or she has had disease for 20 years, the risk is almost 8%. And once he or she has had disease for 30 years, it's as high as 18%. So the longer the duration of disease, the more likely you are to get, you are to have a risk for colorectal cancer. So this is not age, this is the duration of disease. This is diagnosis of since onset of symptoms. 2% at 10 years, 8% by 20 years, and 18% by 30 years. This is the paper which showed this pool data. And how common is it? I mean, a lot of clinicians also believe that ulcerative colitis associated colorectal cancer is not common in these parts of the world, which is far from the truth. There was this meta-analysis which was done by the AIMS group and published in Lancet Gastroenterology in 2017, had shown that at 10 years, maybe the risk is not as high as it is in the West, but at 20 years and definitely at 30 years, the risk is higher in Asians. What about this is the paper which showed these results? And how about India? There has been a study from AIMS, Delhi, which had shown that the risk of developing colon cancer in patients in ulcerative colitis patients in India was 1.5% at 10 years, 7.2% at 20 years, and 23.6% at 30 years, which is fairly high. So that's really high risk. So how do we go about it, and why does this happen? So colorectal cancer, I mean, the colon gets inflamed, as we all know, in Crohn's disease, and persistent chronic inflammation leads to dysplasia. Dysplasia is a pre-malignant state whereby cells start behaving oddly. They start to have in simple words, they start to think about having a mind of their own. And colon cancer is the stage where these cells actually have a mind of their own. They multiply erratically, invade tissues. That's what we call colon cancer. So this is what happens in ulcerative colitis. Whereas the normal colorectal, sporadic colorectal cancer occurs in average risk individuals, starts with an adenoma. It actually happens in normal colon gets a hyperproliferative or hyperplastic polyp, turns to an adenomatic polyp that is small, then large, develops dysplasia, and then carcinoma, which then gets invasive. So, in ulcerative colitis patients, who's at risk? Patients who have a longer duration of disease, that is, patients with 30 years of disease duration, have a higher risk than patients who have just say 1 or 2 years duration of disease. Definitely more than in 30 patients with 30 years disease definitely have more risk than patients with 10 or 20 years of disease activity. Pancolitis, when the entire colon is affected by ulcerative colitis, when the extent of ulcerative colitis involves the entire colon from the rectum to the cecum, you call it pancolitis, and patients with pancolitis have a high risk of developing colorectal cancer as compared to patients with, say, a disease which involves the left side of the colon alone. Patients who have had their disease starting in before onset of adulthood have a higher risk. Patients who have primary sclerosing cholangitis. Hello, Nikhil, can you hear me? Yeah. So people with primary sclerosing cholangitis is an extraintestinal manifestation of ulcerative colitis and Crohn's disease. So if a patient has coexisting primary sclerosing cholangitis, he or she is at a much higher risk of developing colorectal. and an average and the usual patient with ulcerative colitis. If someone has a first with colorectal cancer, again the risk is high. Patients with inflammatory polyps, pseudopolyps, they are at a higher risk. Patients with persistent inflammatory activity that that had lasted a pretty much good period of their life, they have uh, higher risk of developing colorectal cancer. Patients who smoke, again, also have a higher risk of colorectal cancer. So some of these are modifiable. Most of these are modifiable risk factors. Smoking is definitely a modifiable risk factor. The others, there's pretty much nothing. Uh, these are more non-modifiable risk factors, but there are things you can do. I'll speak about them in the coming slides. So, how to mitigate the risk? How to decrease the risk of developing colorectal cancer? So, most of you who are having ulcerative colitis are probably already on 5-ASA. Asacol means maybe having maybe having one of the uh, brands of 5-ASA. So 5-ASA is a Mesacol is one, Vegas OD is one, you know, or there are plenty of Mesa Hens is one brand. So there are plenty of brands you may be having. One of these brands, the brand doesn't matter, but the molecule matters. Even if you have control with, if you require azathioprine and have disease control with azathioprine, you may still receive small doses of 5-ASA just to reduce the risk of developing colorectal cancer. So, in patients with coexistent primary sclerosing cholangitis, there are drugs called colic acid is thought to reduce risk, but it's not conclusively proven to reduce risk of colorectal cancer. And there is this vitamin called folate, which is also uh, has a plus or minus benefit for reducing colorectal cancer. But IASA is the drug which has the strongest evidence among molecules. So we spoke about medical measures. Then medical measures need always be supplemented with screening. And how to screen? Colonoscopy. Colonoscopy is the gold standard. Traditional sporadic colon cancer is screened by, fecal testing for blood, fecal immunochemical tests, CT colonography, and endoscopy. But these are not recommended in ulcerative colitis because ulcerative colitis, even otherwise, can have fecal immunochemical test positivity and fecal occult blood test positivity. So CT colonography only detects polypoidal lesions, and as we discussed earlier, the pathway which the patients with ulcerative colitis uh, take to get to colorectal cancer is the non-polypoidal pathway. So biopsies, colonoscopy with biopsies are the gold standard for detecting for colorectal cancer surveillance ulcerative colitis. So now that you're aware that ulcerative colitis uh, is associated with a higher risk of colorectal cancer, and you're aware that colonoscopy needs to be done to screen for ulcerative colitis associated colorectal cancer, you should know when you should start getting for colorectal cancer. So patients with proctitis alone, that is patients with disease involvement of the rectum alone, they need not have screening for colorectal cancer because uh, they're thought to be at very low risk for, I mean, not much higher than average risk for developing colorectal cancer. Whereas patients with pancolitis and left-sided colitis, they need to start screening 6 to 8 years after diagnosis. So there are people who are more liberal with this time period. There are people who are more stringent with it. Some people start at 6 years. Most people start at 8 years. There are some people who start much later. That's at 15 years of left side college. But you know, because it's a preventable disease and it can be detected at early stages. I think uh, patients with so what I was saying is this is very important. Uh, Patients with concomitant PSC need to have screening starting at diagnosis and then yearly thereafter. This I can't emphasize this. Uh, yeah, it needs to be emphasized uh, a lot because patients with primary sclerosing cholangitis are at very high risk of colorectal cancer. They need to be screened at diagnosis for colorectal cancer and then yearly thereafter. Patients with a strong family history of patients with a strong family history of colon cancer, they also need to start screening early. How early? It depends on, uh, you know, you need to discuss with your doctor. It's usually, if you have a first degree related to colorectal cancer, screening should ideally start at least 10 years from the uh, age of age at which 10 years before the age at which your relative was diagnosed with colorectal cancer. Patients with pouch, the rectal cuff, the small amount of rectal cuff that you have left behind, that needs to be screened 1 year after surgery. And this is again something that needs to be emphasized. Screening should be done only in remission, while in remission. While in remission, in the sense that when you're symptom free for ulcerative colitis and uh, when the colonoscopy shows no inflammatory activity. So once you've undergone screening, how do you know if it was adequate? So the duration of colonoscopy is an indicator. The longer the duration, the better it is. It has to be at least 6 to 8 minutes or longer. It's usually if chromo endoscopy is performed and biopsies are also taken, it is uh, usually going to be fairly longer than 10 minutes or even 15 or 20 minutes. So the longer it is, the better. So don't rush your doctor to uh, get the colonoscopy done faster. It has to be the slower the better. The preparation has the better the preparation, the better. Ideally, if you had when you've had a diagnosis of ulcerative colitis, maybe you had a colonoscopy which was a sigmoidoscopy, which was done without preparation. But when done for screening for colorectal cancer, it has to be prepared very well. And the quality of the endoscopes also matter. Just like you have high definition television monitors, endoscopes also can be standard definition or high definition. So we need high definition wide endoscopes for optimum, for the best results. And chromo endoscopy, that is the ideal colorectal surveillance colonoscopy would be done with a dye sprayed colon while doing colonoscopy. The preferred dye is 0.1% indigo carmine, but methylene blue can also be used. And and then the other metric you need to look for is biopsies. Uh, Biopsies have to be taken very liberally. 4 biopsies every 10 centimeters, with 4 quadrant biopsies every 5 centimeters from the rectum. So what you need to, these are all jargon, but what you need to know is a minimum of 33 biopsies of biopsies need have to be taken. And it has to be done while the patient is in endoscopic remission. That is when the colon is not at all inflamed. So when you're symptom free and the colon is not inflamed, uh, is when screening colonoscopy has to be done. So what do you look for? Longer the better. The better prepared, the better. A high definition white light is the best endoscope you can have to for screening colonoscopy to be done. You need to have chromo endoscopy along with high definition white light. It's okay if you have a you know higher quality endoscope, but this is the bare minimum. Chromo endoscopy is also again required. Biopsies need to be at least 33. You need to be in endoscopic remission. If all of these criteria are met, you can be rest assured that you had a good screening colonoscopy. So, what if the doctor found some lesions during colonoscopy? If they're visible lesions, they need to be resected. If they're visible lesions, they need to be resected. That means they need to be removed during endoscopy itself. And if the resected polyps are if the resected polyps are if the resected polyps are more than 10 millimeter, the next surveillance should be done in 1 to 6 months and yearly thereafter. If the polyps are less than 10 millimeter, then yearly. Further, the pathology report also has a role in playing how frequently further training or surveillance is required. So it's a complex decision, best left to your treating clinician. But what you need to know is if you have had a lesion that's visible, a polyp that is visible on endoscopy, uh, if if it can be removed by endoscopy itself, it has to be removed by endoscopy itself. And the size of the polyp as well as the pathology report would determine how often you need to get screened after the first colonoscopy. That's if lesions are found during colonoscopy. What if lesions are not found during colonoscopy? So, why is it that we worry about lesions which are found in colonoscopy? So it's these polyps, which are small projections in the normal colonic mucosa. It's these polyps which turn to dysplasia and malignancy or colorectal cancer. So, like they say, nip them in the bud. That's what we are doing when we are removing the polyps is we are nipping them in the bud before they become cancerous. At this stage itself, you're cutting and removing the polyp with endoscopy alone, so that they don't turn to the next stage, which is the cancerous stage. So, what if uh, there are no lesions which are found during endoscopy? By endoscopy, there were no lesions detected. You still would the doctor would still have taken a lot of biopsies. I told you a minimum of 33 biopsies would have been taken. These biopsy reports, these biopsies should be evaluated against pathologists, and if dysplasia is present, if this word is present in the uh, pathology report, it indicates that there is a pre-malignant potential. The dysplastic cell is a pre-malignant cell, a cell that is likely to turn into cancer. So there are two kinds of dysplasia: low grade and high grade. The name itself indicates low grade is a better form, and high grade dysplasia is more towards is a cell that has turned more towards the cancerous side. Low grade dysplasia is plus or minus. It's in the eye of the beholder. Should be confirmed by a second pathologist as well. If it's high grade dysplasia, without a lesion that is visible on endoscopy, if it's not visible on endoscopy, it cannot be resected endoscopically. If it's not visible on endoscopy, it is not possible to resect it endoscopically. So it needs to be followed up with other treatment modalities. What the treatment modalities, I'll tell you. So, after your first screening colonoscopy, how frequently should you undergo further colonoscopies? It can be 5 yearly, 2 yearly, or annual based on the risk. So, it depends on the person's risk of developing colorectal cancer. So, how do you assess the risk of developing colorectal cancer? I'll tell you in subsequent slides. Patients with high risk lesions on endoscopy and higher clinical risk may require a tighter schedule, maybe even annual. So, if someone is having ulcerative colitis that is affecting less than 50% of the colon surface area, 5 yearly colonoscopy would do. If there is extensive colitis but with mild endoscopic or histologic active inflammation, again 5 yearly colonoscopy would do. 3 yearly colonoscopy is better when you had post-inflammatory polyp or colorectal cancer in a first degree relative older than 50 years, or when you have extensive colitis with moderate to severe endoscopic or histological inflammation. That is extensive colitis with moderate or severe, severity, colorectal cancer in a first degree relative. First degree relative means father, mother, sibling, basically. Mother or sibling. So if you had a first degree relative older than 50 years who has had colorectal cancer, or who had post inflammatory polyps, then you need to have 3 yearly colonoscopy. Annual colonoscopy is if you had a structure, if there is a dysplasia within the past 5 years in a patient who declined surgery, primary sclerosing cholangitis, including even the patient has had liver transplant, primary sclerosing cholangitis, he or she still needs to undergo colonoscopy. And if the colorectal cancer was in a first degree relative and was diagnosed younger than 50 years of age. So these are the highest risk patients for developing colorectal cancer. They need to undergo annual colonoscopy. So how long should I follow up? You need to follow up for lifetime. It is important because it's the earlier uh, the colorectal cancer is detected, the better. So is that bad news? No, I'll tell you why. So when dysplasia is visible, that is an endoscopically visible lesion is present, it can be removed by during endoscopy itself, and depending on and the rest of the management would depend on the biopsy report. There is low-grade dysplasia in a lesion that is not visible. You need to follow up with a chromo colonoscopy. That is indigo dye-based colonoscopy. And if lesions are any lesion is visible during, once compared to white light endoscopy alone, if you had a colonoscopy with dye spray, it makes previously invisible lesions visible. If such lesions are made visible by a chromoendoscopy and these are endoscopically resectable, then it needs to be resected or cut during endoscopy itself. If someone has high grade dysplasia, it needs to be followed up with a chromocolonoscopy. If visible, uh, it needs to be resected endoscopically. Otherwise, for patients with no lesions that are detected endoscopically, but random biopsy taken through high grade dysplasia, these people need to undergo surgery because colorectal cancer, once developed, is uh, is of higher has worse outcomes than pancreatic colorectal cancer. If patients with ulcerative colitis develop colorectal cancer. So it's better to prevent colorectal cancer and get a surgery done if random biopsies have shown high-grade dysplasia. So this is the inflamed colon can develop colorectal cancer. The alternative is to get regular screening colonoscopies done. So what you need to do is avoid the risk of colorectal cancer and get regular screening colonoscopies done. Like I said, a screened colon is a happy colon. If you've had a colonoscopy done and there are no visible lesions and random biopsies show no dysplasia, it's a happy thing. And even if lesions are found, dysplasia is found, that's also good news because you prevented colorectal cancer by detecting dysplasia. So either ways, getting a screening is good news anyway. So that's all. I'll take your questions.
Thank you, sir. Thank you. Like that's very informative, and I think like we have got like 6, 7 questions. So like first question which
Okay.
I want to ask from my side is like generally in patient groups, what happens is like just about this topic whenever we talk, most common response is that oh we haven't seen anyone with UC or Crohn's get like a cancer or something. So like in your practice, do you
So
get patients like that?
yes. The thing is, so this is uh, this many clinicians used to, ulcerative colitis never used to, I mean, people never used to diagnose ulcerative colitis in India till 20 years back. So 20 years back, because I've been practicing for, since I've been learning gastroenterology. I started learning gastroenterology in 2015. So you know how the AIMS IBD clinic is 7,000 patients with IBD. We get to see the whole spectrum of diseases in over there. But people who got trained 20 years back, during their training, they never saw a patient with ulcerative colitis. Because it was, ulcerative colitis and IBD generally uh, starts, uh, you know, uh, while it's the hygienic conditions and the environmental factors are getting improved. So the more developed countries would have a higher prevalence of inflammatory bowel disease. India is in that transition stage. IBD never used to be there in India. Now it is increased in prevalence, and in the next 20 to 30 years, when conditions here improve, we can see that the prevalence of ulcerative colitis and Crohn's disease will improve. So, what I need to say is, 20 years back, we didn't have ulcerative colitis and Crohn's disease here. And the risk of ulcerative colitis and Crohn's disease is tremendously high when the follow-up is 30 years. So I told you the statistic. When you've had a disease only for 10 years, the risk is something like 2%. When it's uh, when it's 20 years, it's 7.2%, and when it's at 30 years, it's a staggering 23%, which is a very high number. So as we have more and more ulcerative colitis patients in India who have completed 20 and 30 years of disease, we'll be seeing a lot of mm, colorectal cancer in ulcerative colitis patients. That's one thing. Second thing is this study, which was done in AIM in 2017. It was published in 2017. It was done by Saban. You may know Saban. He was my senior in DM. This was his thesis actually, and he the, in this study itself, they had shown a 23% risk of uh, colorectal cancer in patients with ulcerative colitis at 30 years. So this data from India itself. So that means this problem exists in India, and it's going to be much more prevalent in India in the coming years as we have more and more ulcerative colitis patients who pass 30 years of disease duration.
And so, like,
Yeah.
for patients
Any
with
other-
a normal disease, like they have to get screened after 6 to 8 years. And for people who have a first degree
Yeah.
relative, they have to get screened much earlier. I think, like you said,
It has to be much earlier. So the thing is, we are not sure how early because the data is still not there. But to be on the safe side, you can get screened at diagnosis itself. Supposing, so one thing we know for sure, if you had a first degree relative, a sibling or a parent who has had colorectal cancer at 36 years, then it means anyway, even if you don't have ulcerative colitis, you need to get screened 10 years before that age. That is at 26 years.
okay.
So the relative has had colorectal cancer diagnosis at 36 years, you need to get screened at 26 years, even if you don't have uh, ulcerative colitis. If
Okay.
you have ulcerative colitis, you get a screening done immediately. You know what's there. Like, as far as colorectal cancer is concerned, uh, you know, mm, it's not a good disease for patients with ulcerative colitis to have. Colorectal cancer is one of the better cancers to have. Average risk people have to choose between lung cancer and colorectal cancer. Colorectal cancer is better, but for patients with ulcerative colitis, the worse outcomes. than patients with sporadic colorectal cancer.
And
Yes.
so there is a small minority of patient like there are some studies also that smoking is like protective in UC, but it's like
Yes.
this. So I think there's
Yes.
this opposite
So,
thing.
so I'll tell you one thing. Uh, I was expecting this question when I put that bullet point in my slide.
Yeah.
So so for Crohn's disease, I'll tell you why no patient with ulcerative colitis should smoke. I'll tell you why. Because Crohn's, 10% of patients who were diagnosed with ulcerative colitis are going to be subsequently diagnosed as Crohn's disease. It's probably an initial, they colonic phenotype of Crohn's disease looks exactly like ulcerative colitis. So even if you were diagnosed with ulcerative colitis, subsequently it's likely that the diagnosis changes to Crohn's disease. You may initially have had Crohn's disease itself. Not that your ulcerative colitis changed to Crohn's disease. It's that you had Crohn's disease right from the beginning. So that's one thing. So you may, in fact, be having Crohn's disease, even if the initial diagnosis was ulcerative colitis. And smoking is a very, very, very bad thing for patients with Crohn's disease. That's one thing. Second thing, ulcerative colitis associated colorectal cancer is much higher in patients with uh, ulcerative colitis who smoke. Colorectal cancer risk is much higher. The third thing is not just, not just these extraintestinal malignancies higher in even not tobacco, but for patients with ulcerative colitis, there is this additional problem of many of these patients are having immunomodulators, azathiopathy, for example, which when you're having immunomodulators, there's a tendency for cancer cells to exceed immune regulation. So again, even for average risk in patients with no ulcerative colitis, the risk of extraintestinal malignancy is high. Patients with ulcerative colitis who smoke, and the lesser incidence of ulcerative colitis in smokers, the reduction in risk is very small for nicotine or tobacco to have a therapeutic role in ulcerative colitis. So no one should smoke, and patients with ulcerative colitis definitely. No one should smoke, not just patients with ulcerative, but
Yeah.
no one should smoke. Yes.
And sir, like you said, like patient should get screened. So let's say like a patient has in very long term remission, like 20 years, 30 years. So like even
Hmm.
they have the same amount of risk, or like even they should get screened, like because they might think that okay, my UCS in remission since 30 years, and I don't need to get
So,
screened.
so if they've had long duration of remission, their risk is definitely lesser than patients who are continuing to have uncontrolled inflammation. But still, they need to get screened because even though their risk is lesser than patients with persistent inflammatory activity, they still have a higher than average risk of developing colorectal cancer. So they need to continue to get screened according to recommendations. But the interval, like you said, like we saw earlier, can be less frequent, can be as uh,
5 years.
as as 5 years. Yes.
It's like this high grade dysplasia. You said like it's invisible, and
Hmm.
like we have to have surgery if that's like present in the pathology report. So
Yes.
like I'm speaking for a patient, but like how we think. So like we might think that okay, now it's non-visible. Then maybe in like few times it will get visible, and they will like surgeons will cut it, and like maybe I won't have to have surgery. So like is that kind of thinking
So
correct?
no, no, no. So that is a problem. So when so there are two things you're doing at the same time when you're undergoing a screening colonoscopy. One is you're looking for lesions that are visible. Second is you're taking biopsies. So if there are lesions that are visible, you can cut it off. It's that's that's the easier part. But a high grade dysplasia that has not resulted in a visible lesion, that's the stranger thing. Like I said, I had shown in my slides previously. um, so I'll show you that. So this is the pathway which ulcerative colitis patients with ulcerative colitis patients take before they develop colorectal cancer. They develop dysplasia and then they develop colon cancer, as opposed to the sporadic colorectal cancer, where patients actually develop a polyp, a visible lesion, and then they develop dysplasia on the visible lesion. So patients with ulcerative colitis very often do not have a visible lesion, but the next time when you're looking at it, if it becomes visible and it's a cancer, it's not a good thing to have. So what we are aiming to do is uh, you know preventing colorectal cancer, even when so the problem is that uh, the colon is probably 70 centimeters in length, and with 33 biopsies, one biopsy forceps is just 5 millimeters in size. So by 33 biopsies, what percentage of the surface area are you actually screening with random biopsies? It's it's less than 1% of the you know. So once you've had a resected specimen, had a colectomy done for high grade dysplasia, and if a rigorous pathologic examination is done, many of these patients actually have frank colorectal cancer also histologically, a small foci of frank colorectal cancer also. So it's better to prevent colorectal cancer than treat
So
it.
yes, sir.
So
So like
so
basically, this cancer can develop microscopically also that we can't see.
yes,
So
yes.
we don't have to
So
wait for it to become a lesion.
it always starts microscopically. It always starts microscopically and then becomes visible.
Like
Yes.
when it becomes visible, it is possible that it already might have become cancerous, and then at that point, like it's too late to like colorectal
Yes.
prevent colorectal
Yes.
cancer.
Yeah. Yes. Yes.
And so
So the idea is to cure colorectal cancer, not to actually treat it, because it could actually be colorectal cancer and ulcerative colitis, as compared to sporadic colorectal cancer, is associated with bad clinical results. So it's better to prevent it than treat it.
and this surgery is this colectomy, ostomy surgery.
Yeah.
And so just
So it's
yeah.
uh, when possible, we will always try for a pouch as a two-stage or a three-stage surgery when possible. And even if you've had a pouch done, there is a small amount of rectum that's remaining that needs to be on colorectal cancer surveillance again.
And so
Yes.
final question is like uh, for Crohn's patients or like people with Crohn's colitis who have a lot of colon involved, like what is the risk for them, like, and how is it for them? Just two, three sentences.
So, so the thing is, this has to be a separate topic altogether. It needs to be covered in a separate topic altogether. So patients with colorectal cancer who have patients
Crohn's
with
disease.
Crohn's disease who have colonic involvement, colonic predominant disease. They also have a higher risk of colorectal cancer. They also need to be on colorectal cancer screening. But we will have a separate talk on that in some time, because that's also a very important topic. The minutiae, the small details of the screening in Crohn's disease varies from that in ulcerative colitis. So for patients with Crohn's disease, we'll have a separate talk
Yeah.
for colorectal cancer screening.
And one more question, sir. Last question. This chromo endoscopy, like most patients, I don't think I've heard about it. So Is it like available in most hospitals, or like do we have to go to specialist centers or something?
So the thing is, it's indigocamin is a cheap dye which is available in most endoscopy suites. But detecting small lesions depends on the endoscopist. The the higher, I believe patients with IBD needs to be managed with by people with specific expertise in IBD, not the mm, specific interest in IBD. So, a person with a specific interest in IBD and endoscopist would be very vigorous in examining uh, uh, the colon during a chromo endoscopy. So, the intent of there is some amount of inter observer variability in this. So, the higher the expertise, the better.
Thank you. So that was all of our questions, and we are very thankful to you for like giving. I think we had planned it for 25 minutes, but it's like 50 minutes. So thanks a lot for giving so much of
Yeah.
your time. And yeah, please stay safe
Thank,
and
thank
take
you,
care.
Nikhil.
Yeah, yeah.
Thanks a lot for making me.
Yes, we are like
Uh,
honored to have you.
well,
Honestly, like it's like great pleasure to have like doctors I have met, and now I'm talking to them on this stuff. Like it's very informational also, and like I think like it's like we haven't had these kind of talks before. So I think for that, like I'm especially very grateful to you for that. Yeah.
okay, thank you. Just one more thing. If any of you have any doubts regarding this, do email me or feel free to WhatsApp me on
Yes.
this number.
Sure, sir. Yeah.
We will keep this open for a
Yes, sir.
while so that
We'll post
people
it
can.
separately also, sir, like in the video, and then
Okay.
yeah. Yes, sir. Okay. Thank you so
We'll have a few pamphlets also for promoting colorectal cancer screening in your forum. We'll have a couple of pamphlets also sent.
much. Okay, sir. Then
Okay.
I'll get that from
Thank
you
you.
next week.
Thanks a lot.
Okay.
Thanks a lot for.
So,
Thanks.
yeah. Thank you, sir. Thank you.
Thank you.
Bye.